All right, we're trying something a little bit non-conventional here. I appreciate y'all's flexibility. Unfortunately, I have to attend school tonight myself. So Dave and I are trying to do this a little bit asynchronously, and I'm going to call out slide numbers as we go through. So currently I'm on the title slide, Intravenous Fluids and EMS, a primer. Really what we're trying to accomplish here is distinguish between colloid solutions and crystalloid solutions, discuss what a crystalloid solution is indicated for, and where it can be potentially harmful for a patient, and then understand the difference between somebody who's getting a maintenance fluid, a resuscitation fluid, and an administrative fluid. So in slide 3, it's a little bit of history of the intravenous fluid therapy, and the real reason I put this in there is because normal saline is an oxymoron, a lot like well-behaved children and military intelligence. So Hamburger in 1883 suggests that human blood is 0.9% salt. And this is a very big oversight on his part because we are not 0.9% salt. In fact, we're not even close to that. How does normal saline become the fluid of choice? During the Vietnam War, there's a large number of hemorrhagic shock patients, also a large number of heat casualties, and we were outstripping the blood supply. So the heat casualties obviously did not need blood, they needed fluid replacement and they needed salt replacement. So this normal saline solution that had been present at that time for about 100 years came on as a primary resuscitation fluid of choice. And surgeons said, maybe this would work in the blood deficient patients as well, and started giving it to patients in hypovolemic shock. Pressure improved. Unfortunately, the patient did not. So we've learned about acute renal injury and ARDS, or adult respiratory distress syndrome, which back then was called Da Nang lung. Now we have a more scientific name. But the overall point is that the fluids that were given to these patients who were in a traumatic situation ended up hurting them more than helping them, and their outcomes suffered for it. Right about the same time as normal saline came on, Sidney Ringer invented his own solution. And then in 1930, a pediatrician by the name of Dr. Hartman added lactate to the solution. She called it Hartman's solution, or Ringer's lactate. It is interesting to point out that a pediatrician is generating this fluid because at the same time there's a large cholera epidemic in the United States, largely from immigration. And children were dying at a cyclical rate from diarrheal illnesses. So the lactated Ringers was designed to resuscitate children who were in pretty significant volume depletion from diarrheal illnesses. On slide 4, there's a little cartoon of crystalloid solution and colloid solution. And we split this up into balanced electrolyte composition, essentially the same number of sodium as there is chloride. The whole idea behind crystalloid solution is to expand the total extracellular volume by increasing the pressure. All of that stuff that sits in the extracellular fluid creates a pressure that then pushes on blood vessels like capillaries and veins and sometimes even arteries or arterioles. It depends on how high the pressure is on the inside of the artery and how fast the blood is moving. But the idea is to increase the extracellular volume, essentially the fluid around the tissue. Colloid solution is designed to increase oncotic pressure. So essentially the pressure inside the blood vessel from all the stuff, the proteins, the immunoglobulins, the cytokines, all the things that make up components that are floating around in your serum. That's what colloids are supposed to do. And it's designed to drag electrolytes like sodium, chloride, magnesium, potassium into the vessel by creating more stuff on the inside than on the outside. So with us being biological organisms, we operate on osmosis and not diffusion. This may seem like minutia and chemistry/biology stuff, but that semi-permeable membrane is really why we have jobs. If we did not have semi-permeable membranes, it really wouldn't matter. We would just have diffusion, and we could dump simple water into the solution, and it would just equilibrate, or we could add salt, and it would just equilibrate. But that membrane does a specific function by keeping stuff on the outside out and then stuff on the inside in. And if we get the fluid wrong, if we give somebody a hypotonic or a hypertonic solution, our cells will suffer. So on slide 5, on the right side, you see that there's several red blood cells, and if we give somebody a hypertonic solution, it's going to suck fluid out of those cells, and they're going to look kind of like, I don't know, some kind of weird flower or something. The whole point here is that it's losing intracellular fluid, and that's going to complicate the ability of that red blood cell to carry oxygen and deposit oxygen at the cellular matrix, which is called cellular respiration. The converse is true for hypotonic solution. If there's more stuff on the inside of the cell than there's on the outside, then the water is going to move through the membrane to the inside of the cell, and eventually that cell is going to reach its maximum capacity and it's going to rupture. What's on the inside of red blood cells? Lots of potassium, lots of iron, lots of phosphate. None of that stuff is good for sick patients, particularly the potassium. You usually get rewarded with that with a tachy-wide complex tachycardia. So we shoot for isotonic solutions. Without having anybody have a seizure, I'm going to throw something up here called Starling's forces and Pascal's laws. And basically what this means is water is going to follow a diffusion gradient from higher pressure to lower pressure, and from higher solute concentration, from lower solute concentration to a higher solute concentration. What we are seeking is low hydrostatic pressure on the inside of the vessel and high oncotic pressure or osmotic pressure on the inside of the vessel. The converse is true on the outside. So in this extracellular matrix and the stuff that surrounds blood vessels, we want high hydrostatic pressure and low osmotic pressure. So we want the stuff, the proteins, the blood components on the inside and the fluid on the outside. How do you increase hydrostatic pressure? You put pressure on the wound. So if somebody's bleeding, they're leaking out fluid, what you're not seeing is a bunch of little holes that are poked in the blood vessel where fluid is evacuating from that vessel, and eventually you'll have edema, like you have seen with every other injury. If you put pressure on that, you're increasing the hydrostatic pressure around the vessel, trying to push that fluid back in. Now we also have to add some stuff in the form of a colloid solution to drag that stuff back into the vessel and increase the patient's blood pressure. Sometimes it may just be as simple as adding crystalloid, such as a heat case or sepsis, but when we're talking about trauma, we want to add some colloid in order to increase the contents of the vessel. So Starling forces can really be simplified down to, when providing resuscitation, we want to limit filtration, i.e. we want to limit the amount of hydrostatic pressure inside the vessel that's pushing stuff out, and we want to maximize absorption. Recall from when I said that the oncotic pressure or the osmotic pressure on the inside of the vessel drags stuff through the membrane from the outside in. So we're trying to increase the vessel's oncotic pressure, i.e. draw stuff through the membrane, and decrease the vessel's hydrostatic pressure by applying a higher hydrostatic pressure in the form of compression. So what the fluid is made up matters as well. On this chart here, in the second column, are the standard reference values for chemistry 7, and these vary from lab to lab, but they don't vary all that much. Largely your sodium in your blood somewhere around 140. The lower limit of normal is 135. The higher limit of normal is 145. Note that normal saline has 154 millimoles per liter, so there's approximately 10 to 15 more millimoles. That makes this a hypertonic solution, and if you look at the tonicity, or the number of osms per liter, it's almost 310. You compare that to what our normal osmolarity is, and we're running about 280, 290. You can see that we're going to have fluid movement from the cell out of the cell into the extracellular matrix. You're going to dry up tissues, and you're going to increase the extracellular matrix. This is going to make edema worse, and this is where that 3-to-1 rule comes from. If you remember people saying if you lost a liter of blood, you had to give them 3 liters of fluid. It's because only a third of that fluid remains on the inside of the vessel. The other 2/3 accumulates in the extracellular compartment, what's called the third space. Same is true for chloride, and chloride actually has a more important role because our body doesn't tolerate high elements or high composition of chloride for very long without injuring the kidney. Now this, again, may seem like a lot of minutia, but this is important because high chloride concentrations, chloride is a positively charged anion. So is hydrogen. Hydrogen is important for the pH balance. We'll start exchanging chloride for hydrogen, and we'll end up creating an acidosis, which is going to make our patient worse. Lactated ringers is a little bit better. It's a little hyponatremic compared to our tissue. It's about the same or relatively a little bit higher compared to on the chloride side, and also has some potassium and some calcium. And if you add lactated ringers, which is what we use, we don't in order to get Ringer's solution true, you'd have to have the pharmacy compound it for you. There's a little bit of lactate in there as well. There's a third solution I'm going to mention. It's called Plasma-Lyte, and this is truly isotonic. It is basically blood serum. So why don't we use this in EMS? Normal saline's about $1 a liter. LR is about $1.50 to $2 a liter. Plasma-Lyte's $12 a liter. We would go broke just using fluids. But for the sake of this this lecture and for your general awareness, Plasma-Lyte operates just like normal saline, except it doesn't have the high chloride concentrations or the high sodium concentrations or the differences in tonicity, and is far easier on the cell matrix. So this little cartoon that I made is largely designed to show you what the tonicity looks like if you're a visual learner and the overall flow. So normal saline, you're getting a lot of filtration. You can see that the blood is being, or the serum, the fluid is being pushed out of the vessel into the extracellular compartment, that quote-unquote third space. This is largely due to tonicity and the cellular composition, or the elementary composition of the elements, the sodium and the chloride. Lactated ringers, you're going to favor absorption, but it's really not going to be all that much because that's a relatively hypotonic solution. It's near isotonic. If you had to pick between the two, LR is far better than NS for this very reason. The direction of the arrow matters. Plasma-Lyte, the fluid should move across because it should be in homeostasis. Really, the composition on the outside should be the same as on the inside, and whatever we put in the vessel really is designed to stay in the vessel. We might get a little filtration from changes in hydrostatic pressure or changes in oncotic pressure, but it really should be negligible. So this is a little cartoon of the nephron, and what I'm trying to point out here is that this high chloride concentration that we create with with the normal saline ends up hurting that distal tubule, that part of the blue/yellow there, and we get a type 1 distal renal tubular acidosis. The important part here is that you understand is that this is an impaired hydrogen ion secretion. We start exchanging chloride for hydrogen. We start retaining hydrogen. So the nephron, the part of the kidney that actually does the work, no longer kicks out that hydrogen. You end up with an acidic solution and a relatively alkalotic or a basic urine. And then it actually affects the way the kidney can function, and you'll get a renal insult. So the creatinine will go up, the BUN will go up, and the patient overall ends up having what can be a fairly significant renal event. So again, on the top of 10 in big bold letters, I say there's nothing normal about normal saline, and recall that Hamburger, who invented the solution in 1883, totally botched it by thinking that we were 0.9% salt, when in fact we're not even close to 0.9, we're about half that. So this non-gapped metabolic acidosis, this slide exists on slide 11 primarily so that you understand that by us giving chloride, we're having renal loss of bicarb, retaining the hydrogen ion or retaining acid, and we're actually inducing an acidosis. I think very few people who are in medicine try to hurt their patients. I don't think that they do it maliciously, but now that you have been apprised of what the situation is, I'm sure you'll all stop giving high chloride solutions to really sick patients, especially in large volumes. Colloid solutions, if we go back to the first couple of slides, we're talking about absorption and filtration. This is an absorption fluid. So as this fluid moves through the vessel, it's going to suck all that stuff on the inside, and it's going to decrease a lot of that edema. But more importantly, it's going to pump up those blood vessels and fill it with a solution that is designed to stay within the vessel and increase the blood pressure. So we've got a couple of different options. We've got natural colloids and synthetic colloids, and the one probably most frequently used in medicine is the hydroxyethyl starch, or HESPAN. This has been used in the military for years, since I was an ensign. It's a decent solution. It's not great. You can't give any blood products with it, and it actually, if you give it in high volumes, it will tag platelets for destruction. You end up creating a thrombocytopenia, lowering the platelet count, and then causing a clotting problem. So the natural colloids that we can give are the whole blood, fresh frozen plasma, or albumin. And we frequently give albumin to patients who have liver disease because they are losing albumin from filtration from their liver failure. And this is why people end up getting the big edema around their abdomen and ascites. There's other reasons to give people albumin in medicine, but what I'm going to focus on for this lecture here is the idea of whole blood. And if somebody is bleeding and they have a low blood pressure and they're in hemorrhagic shock, then they need a colloid solution that's going to plump up the vessel, increase the pressure, and keep that blood in the same area or within the vessel. In addition, we're going to use all the beneficial clotting effects that are in whole blood, like clotting factors and platelets, to help repair that tissue. And when Dr. Picorni talks later on this evening, he's going to tell you about the glycocalyx and what whole blood does to repair that. So I wanted to highlight a couple of studies that came out within the last 2 years, and this was done by the folks down in Vanderbilt who looked at whether or not it made a difference in both non-critical and critically ill patients to give them a quote-unquote balanced solution that was more physiologic, comparable to human serum, or whether it made a difference if you gave them chloride or if there was no difference. So they took about 13,500 patients. These are all not critically ill patients. These patients ended up getting some fluid. They had to get at least 500 milliliters, and they may have been somewhat volume depleted or heat cases or whatever. And they split them up into 6,600 or 6,700 of normal saline and LR. If they got LR, they may have gotten plasmolite as well. What did they find? Well, the patients who got plasmolite or LR had a decrease in the major adverse kidney events within 30 days. So their creatinine was lower and their overall renal insufficiency was lower. A good number of our patients that we see every day end up having kidney problems to begin with. So we're literally taking somebody who may be on the banana peel and just pushing them straight over. This slide here is directly from the talk or from the paper, and really the whole idea is that you see what the arrows are pointing to. It's the lower concentrations of sodium, the lower concentrations of crystalloid, and the higher concentrations of bicarbonate, because we're no longer exchanging hydrogen for chloride by giving them LR, and we're no longer losing bicarb in the urine. And if we were to test these folks' urine afterwards, they would have a much more acidic urine than those who got sodium chloride. The overall point here is that in non-critical patients, they had a lower incidence of renal tubular acidosis and a lower incidence of renal disease or worsening renal function within 30 days. There's another important point here. We treat a lot of diabetics. With the diabetics, they have existing kidney disease. We get a lot of patients who come to the ER from EMS that end up needing CAT scans. Recall that patients who have bad kidneys are not great candidates for CAT scans, but CAT scans are a necessary evil in a lot of emergency medicine to make the diagnosis. By giving somebody LR and resuscitating them with that fluid versus chloride, we may be able to spare them the 1 or 2 nephrons they have left so that we can do the study safely. So you can see how what happens in EMS has broad-reaching effects well into the patient's hospital stay after the ED and long after even they've been discharged from the hospital. How does this compare to critically ill patients? Same study group. They just looked at people in the ICU, 15,000 people in the ICU, and they split them up again into half. The half got normal saline, the other half got LR or plasmolite. They found the same outcome of major adverse kidney events within 30 days was decreased by 1 percentage point, but they also looked at in-hospital mortality, and the normal saline patients had a higher mortality than the patients who got LR or plasmolite. Yeah, it was 1%, and that may seem trivial, but if I'm the patient who's getting the fluids, I want to be on the 1% that lives, not the 1% that dies. So the overall point to take home here is that patients who are critically ill had similar outcomes. There was a similar observance effect by giving somebody a high chloride solution and a non-balanced solution. They had worse outcomes. Again, the graphics from the paper showing a relatively lower chloride concentration and a higher bicarbonate concentration. And a lot of these patients who are critically ill were already acidotic, so we were adding insult to injury. We recently started carrying hypertonic saline. Hypertonic saline is essentially 3 times what the elemental salt is within normal saline. What are the indications for this? Really, it's head trauma, severe head trauma. So this is a patient who has a GCS of either 8 or less, who is going to be intubated, who has isolated head trauma, and we want to keep that sodium concentration as high as possible. Why do we want to keep it high as possible? Because we don't want fluid moving out of the neuron. If anything, we want fluid moving into the neuron. We don't want the brain to swell. So we don't want fluid moving into the neuron. We want it either staying the same or moving out. We don't want to dry it up, because if we suck fluid out, it's going to cause some additional damage and what's called secondary head injury or secondary TBI. But by giving somebody a hypertonic solution, we're going to prevent that fluid from being sucked up like we saw with the red blood cell, and then creating more edema. Edema in the brain increases the intracranial pressure, and an increase in intracranial pressure results in death, which is what we know from TBI literature for the last 50 years. So this is the reason for HTS. What's the take-home point for EMS? Somebody who has a bad head injury, who needs an airway, who has a GCS of 8 or less, can get 200 milliliters of 3% hypertonic saline. 100 ml is given over 10 minutes, 100 ml is given over the remaining 50 minutes, 200 ml in an hour. Let's say you're wrong. Let's say the patient has drugs on board or alcohol, or there's another conflicting data point that steers you in the direction of a TBI when they actually don't have a TBI. You'll do no harm. So having talked to tons of nephrologists and neurosurgeons about this, it really doesn't matter if you give somebody 200 ml of hypertonic saline. If you read every note from a neurosurgeon, they get paid $1.5 million to write their very first line, keep the sodium between 145 and 150. They want that sodium around 148 because, again, they don't want neuronal injury from swelling from a hypotonic solution. So this, again, is the paper that we were talking about from the critically ill folks, and I highlighted here that normal saline was the only solution where NS was actually somewhat more beneficial than LR. Everything else was on the crystalloid solution that was balanced. There is a little bit here about cardiac and NS being somewhat better for cardiac patients, and that largely had to do with the volumes of fluid that patients were getting during cardiac surgery. There's a lot of NS that's given because there's a lot of blood products that's usually given with normal saline, and that probably is just a confounder. But this supports what we already know about TBI. So this is my little schematic here about when to give somebody IV fluids in EMS, and it's broken down into either maintenance therapy, volume resuscitation, or medication administration. So maintenance therapy largely is patients who are not able to eat or drink, and we have to hydrate them. We normally used to give these patients normal saline in the ER and then send them up there, and they would end up getting like 4, 5, 6 liters over the course of a 24-hour event. Really hurt their kidneys. Now we're switching to LR, and this is done via calculations based on their weight and their age. What do you need to know about this in EMS? If you're going to run fluids just to keep the IV open, run LR. Let's switch over to medication administration. Any medications that you guys give, whether that be Zofran or diltiazem or TXA, whatever, needs to be done in NS. All the studies are done in NS, and with the LR, with the lactate in there, you can often cause clumping inside that tube, and you then shut down the whole IV line, or you can make problems within the blood vessel. So for simplicity, any medication that you're going to give to somebody needs to be done in NS. The volume of NS that you're going to give them is really trivial. It's a couple of milliliters as a vehicle to get it into the vessel. Now, on the volume resuscitation side, if the patient is not traumatic and is in hypovolemic shock, recall Dr. Hartman and the patients that she was treating in the 30s who had hypovolemic shock from diarrheal illnesses. It's relatively the same thing we're talking about in sepsis and anaphylaxis, in burns or metabolic disturbances. These patients get LR or plasmolate. If the patient is traumatic and they're in hemorrhagic shock, they get stored whole blood. And again, that'll come later on tonight with Dr. Picorni. If they have isolated head trauma, then they either get 0.9% normal saline or hypertonic saline, depending on how severe their head injury is. If they are a GCS less than 8, need an airway, needs to go to a level 1 trauma center and have a date with a neurosurgeon that night, then they're better off with the hypertonic saline. If the patient has isolated head trauma, it's reasonable to give them 0.9% normal saline. However, remember, 85% of trauma patients are bleeding to death. So if the patient is in hypotension and they're a traumatic injury, they're bleeding from somewhere until proven otherwise, that patient gets blood. A couple of cases here, just talking about which resuscitation fluids to give, and I'm going to let David direct this because I think this is probably better done interactive, and I will talk to you guys about RSI here shortly. Thank you.